All right, rocking and rolling. So some of y'all might have met me before, but some of you might not have, and that's totally okay. My name is Abigail Fisher, and I use she, her pronouns. I am a experienced designer focused on provider technology at the BHA. And today I'm really excited to be presenting the results of the Admin Burden CCAR DACODS Modernization Report. I am one of many on the BHA technology team, and I want to thank all of our team members who contributed to this body of work, and want to especially highlight the co-authors of this report, Chris Pimlott and Mark Gammon. So we'd like to begin today with a land acknowledgement drafted by Denver's City Council. We honor and acknowledge that the land on which we reside is the traditional territory of the Ute, Cheyenne, and Arapaho peoples. We also recognize the 48 contemporary tribal nations that are historically tied to the lands that make up the state of Colorado. We honor elders past, present, and future, and those who have stewarded this land throughout generations. We also recognize that government, academic, and cultural institutions were founded upon and continue to enact exclusions and erasures of Indigenous peoples. May this acknowledgement demonstrate a commitment to working to dismantle ongoing legacies of oppression and inequities, and recognize the current and future contributions of Indigenous communities in Denver and across the state of Colorado. We thank the Denver City Council for those words. So, what will our session look like today? Today, we will be going over our research findings and our recommendations for a roadmap forward. This session marks the beginning of a comprehensive engagement period for these recommendations to ensure that we are truly holding space for co-creation with providers and people seeking care in Colorado. In terms of the structure of today, I'll present out for about 30 minutes to 45 minutes, and then we have held 45 minutes for open discussion. Although we might not have all the necessary people to answer every single question, we will certainly follow up on every single question as needed. We know that many providers are eager to give feedback on this work. We have many ways for you to engage and share your thoughts, including attending live sessions like this. During this session, we want to engage in as much discussion as possible, so feel free to share your thoughts in chat while I present. We will also hold time, like I mentioned, at the end for open discussion. As I present, I won't answer questions, but I will respond to all of them with the help of my colleague Megan when we get to open discussion. Additionally, if there are those who prefer to give their feedback anonymously, which we totally understand, we have a feedback form you can fill out anytime before October 27th. Megan will share that form in the chat, and this is also posted on our project's website, where you can always go at any time for any updates on this project. All pieces of feedback, those discussed today and those submitted through the form, will be publicly responded to by the BHA, a process we'll talk more about at the end of this presentation. Finally, before we begin, we want to deeply thank everyone who participated in this research. We know that every hour spent with us is an hour away from supporting clients. We take this responsibility very seriously and credit the recommendations in this report as solutions created by those closest to the problem. In this case, that is you all, or the providers that worked with us on this research. So thank you for that contribution. As I go through this presentation, one of the key questions I would love you to consider is whether these recommendations would represent a better balance between administrative burden, federal requirements, and measures of quality and access for behavioral health providers in Colorado. I'm just going to pause and let that sink in for a minute. And also to provide some more details on what I mean by balance. So we know that as the BHA, it is our job to balance how federal requirements place administrative burden on providers, both federal and state requirements. But today we'll talk in detail about how federal requirements trickle down into state provider requirements. These requirements seek to establish measures of quality and access for Colorado's and the nation's behavioral health system. Today, however, we know that these factors are not in balance from the experience of providers, that there is far more administrative burden than the benefits providers see from measures of access and quality, and this report seeks to address this imbalance. Addressing administrative burden is even written into the BHA's founding legislation. It's something we're taking very seriously and are acting on with urgency. And I think it's actually very fascinating to go back to this BHA founding legislation because you can see very clearly the need to balance in point A, accessibility of care, in point B, quality of care, and then finally in point C, reducing the administrative burden required to get to those measures of quality and access. So the BHA is a little over a year old, and we're still digging our way out of the technology debt accrued by our predecessor, OBH, which does play a big role in the high levels of administrative burden currently experienced by providers engaged with the BHA as we continue to upskill and upstaff our technology team. This report provides recommendations to better balance the administrative burden caused by CCAR DACODS reports. And we want to acknowledge that this will be one of many projects at the BHA to address different causes of administrative burden, as we know that CCAR and DACODS are not the only causes. All right, so I want to begin, so you don't have to wait for the whole presentation, with the 5 recommendations that came out of our findings from this report. Throughout the rest of the presentation, we will share details at how we arrived at these recommendations and how we plan to act on them. But to begin, I'm just going to detail the 5 recommendations coming out of our work. Number 1, update data model. We know that the data model for CCAR and DACODS must be updated through relevant provider stakeholdering with people seeking care on how they want their identities represented, and finally, a federal review process for compliance. It's our intention to map a more culturally competent data model, providing better options for gender, race, and ethnicity for front-end presentations to providers, while still maintaining federal compliance with the data necessary for the BHA to receive block grants. 2, select data entry system. We know that the technology and the age of the technology used to accept CCAR DACODS is a huge part of the pain point around submitting reports at the BHA. So it's our intention to perform an analysis of existing and potential new technology systems based on recommended design parameters derived from research in order to select a new tech system for providers to enter data into. Next, we must build for episodic reporting. We need to build a reporting environment through both our data model and our selected tech system where we can collect data episodically, aggregating encounters into episodes of care so that providers have a more holistic picture of a client's care journey so they can make better care decisions themselves for that individual. Next, we need to create data analysis dashboards so that we can share this data back with providers so that it can be more use in advocacy as well as resourcing strategizing. And we'll do this by creating standard and customizable data analysis dashboards so providers can track their own progress towards contractual requirements as well as measures of equity. And finally, as made evident by sessions like this, we must prioritize engagement and co-creation with providers and people seeking care. And that will include creating a robust communications and engagement plan to foster trust and transparency and agency for those stakeholders in this process. All right. So those are recommendations. I'm just going to let those sit for a minute. And then I'm going to spend the next 15 minutes or so taking you through how we arrived at those recommendations. And I'm going through all the chat, good sound, that's great. All right, I will keep us moving. So let's begin. How did we get here? Why is the BHA doing this research? That might be obvious to all of you, but how do we, choose different projects at the BHA technology team, and how do we do that prioritization exercise? Down to a sentence, and those on this call can speak to this far better than I ever could. We know that it is a fact that behavioral healthcare providers that care for uninsured, underinsured, and undocumented individuals have to hurdle extreme bureaucratic barriers. And that's really the anchor of why we why we started here. We know this is a problem, and we know that it is affecting the care that this ecosystem can provide to people in Colorado. Accepting any insurance for any behavioral health provider is a hurdle. And if you add Medicaid into that process, it becomes even more complicated. And then if you consider adding additional state funding streams or additional state licensing from agencies like the BHA, very quickly you can see administrative requirements double or triple. It makes logical sense that the more requirements a provider has, the more technology systems you have to engage with, especially if state agencies are still at an early level of maturity around system interoperability. These factors create a really complex tech ecosystem for providers, far outweighing what providers that only access private insurance face. And this diagram seeks to begin to define, how many different licenses and how many different funding streams and how many different reports and billing codes folks need in order to stay in compliance with state agencies. And you can see it quickly doubles and triples. Understanding this, it's easy to see the connection between the behavioral health workforce shortage and the high levels of administrative burden experienced by providers who access public funding in Colorado. We've all seen the news stories. If you're paying attention, this should not be a surprise, and I'm certain it isn't a surprise to anybody here on the call. And administrative burden, we acknowledge, is a large part and parcel of that systemic problem. This report is part of a broader statewide effort to address administrative burden. There are many efforts, even just at the BHA and across cross-agency efforts to address administrative burden. This report in particular is the BHA's technology team's contribution to this wider body of work. We have and will continue to share these findings with other efforts to maximize our impact. And some of those other groups that you might be interested in us talking to, if anybody knows about the universal contracting provision work that is going on, we are working with them to integrate these findings, as well as other data model standardization groups to ensure that we're building data models that can easily be used across many technology systems. And of course, are in deep conversation with HCPF and other state agencies on these findings. We know that one of the major causes of administrative burden at the BHA are CCAR and DACODS reports. Providers that engage with the BHA through contracts to access additional fundings or programs and or to provide opioid treatment programs have to fill out CCAR DACODS reports. At a high level, CCAR are for mental health services and DACODS are for substance use services. More detail about which providers have to submit CCAR DACODS for which clients can be found in our full report, which Megan will share in the chat. As we stated earlier in the presentation, there are many sources of administrative burden caused by the BHA, but we very intentionally began with CCAR DACODS because those reports are the most prevalent today and also the most harmful to providers and their resourcing today. We will tackle other sources of administrative burden in parallel with the implementations of the recommendations outlined in this report. So said simply, this is just the beginning, and we know that we have a lot of work to do on a lot of other different report types and entry points for providers. You might be asking, why can't we simply do away with CCAR and DACODS, which is a wonderful question. And to back into this a little bit, I think it's important to understand where do CCAR DACODS come from and what do they do for us as the state and to the federal level. So this diagram shows that CCAR DACODS are reporting requirements that ultimately stem from SAMHSA block grants. And those block grants are the funds that are used to fund BHA programs, so funds that the BHA passes on to providers. This is very similar to how CMS requires reporting from HCPF on Medicaid enrolled providers. And we know that there's a major overlap between Medicaid enrolled and providers as well as BHA licensed providers, as we referenced earlier. Many people have rightfully asked us, why can't the BHA simply pull the necessary data from other sources? A lot of what's thrown around are 837 or NOMS. Unfortunately, in our analysis, we found that there's enough difference in the type of data required by SAMHSA that there will likely, at least for the near future, always need to be some kind of data collected from providers by the BHA. And although that's the bad news, there is much we can still do to improve data quality, tech usability, and to reduce administrative burden while still remaining in compliance with federal requirements. And that's really where our report and our research begins. So as I mentioned before, we know that one of the major pain points for CCAR DACODS is the aging technology used to ingest that data. We want to acknowledge and shout out our system specialists, especially Troy, Sharon, and Jackie, who have been helping to keep these systems going in the face of limited resources for nearly 20 years. That said, it's time for an update, and we're well aware of that and have the resources ready to go to accomplish better usability across new systems. We also know that the data model being used today for CCAR DACODS is outdated and harmful. For instance, today, CCAR DACODS requires providers to ask clients their sexual orientation, something providers themselves typically would not ask in an intake appointment. There are certain questions that CCAR DACODS must ask, again, because they are dictated by the federal government. Other questions, however, were added by OBH because they wanted to collect additional demographic information for state data analysis. Our recommendations include minimizing data elements to only those that the BHA can solidly defend, either due to federal requirements or a strong use case for quality and access measures that would be shared back to providers and the general public. And I want to make an especial, this is the second time I've presented this today. And in our first session, we had a really great piece of feedback asking, is this suggesting that we're going to take sexual orientation out of the CCAR DACODS? And my response back to that is not necessarily. That's a question that we want to pose to you as a providers community and also to people seeking care. And so it will be part of an engagement after this presentation, after this initial share out, to understand, what do we feel good about and what do we need in terms of data analysis, and not doing a single thing more than we need to do because we know the impact on clients and providers. It's imperative that the BHA address the administrative burden and negative impact on provider-client relationships caused by CCAR DACODS while also remaining in compliance with federal requirements. The recommendations that follow will address these concerns, and the proposed roadmap also considers how this work will integrate and support other admin burden efforts across the state. All right. Just a couple of minutes detailing our research methodology. We focused our research on CCAR and DACODS as we've discussed, but I wanted to pull up our hypothesis and our goals from our initial research plan, because I think it's important to call out the emphasis on how admin burden also impacts clients and people seeking care, not just the providers themselves, in terms of how it takes care time away from them and also causes questions to be asked that clients might not be ready to answer in terms of clinical flow and trust. The BHA's ultimate mission is to improve behavioral health care for people in Colorado. So it's imperative that no matter what the research or focus of a project is, it always must come back to people seeking care in Colorado. We executed both primary and secondary research during this project. From March through July of 2023, we talked with 16 provider organizations across Colorado, selecting them for their representation in terms of tech resourcing, so high tech resourcing and lower tech resourcing, different types of EHRs, different geographies, different types of facilities and mental health settings, different service offerings, and different population expertise. We conducted hour-long interviews and virtual site visits with over 60 individuals from those 16 provider organizations, and the folks that we talked to represented a range of roles, anywhere from clinician to front desk staff, to data and tech teams, to clinical managers, to executive leadership. We also did extensive secondary research on policy, legislation, and past modernization efforts like Compass. Our methodologies are informed by co-design and the importance of designing with and not for, with the ultimate vision of our work being design led by communities closest to the issue at hand. I really love to reference the book Beyond Sticky Notes by K.A. McKercher that gives a really solid understanding of what co-design is, how it can be implemented in civic technology environments. Our findings stemming from that research are as follows. And I think you'll find it interesting how these findings can be mapped directly to our ultimate recommendations and implementation plan. So our first finding was that the data model for CCAR DACODS, like we discussed, is clinically and culturally out of date, especially for data elements like gender, race, and ethnicity. We also heard that providers are losing out on payment and accurate counts towards contractual requirements due to how inflexible BHA technology systems are today. And we also heard that the error resolution process is also quite difficult and time consuming. We heard that the distinction between CCAR for mental health and DACODS for substance use perpetuates the siloing of behavioral health care and creates high levels of data duplication for the rising population of dual diagnosis clients and the providers that care for them. Again, we've talked about technology and the basic usability issues with BHA systems and how that increases the time, effort, and cost required by providers to submit compliant data. We also heard that today the data generated by CCAR DACODS provides limited, if at any at all, benefit to providers and the ecosystem at large. The data really is only currently in active use for contract and funding requirements, not any larger data analysis that is shared publicly. And finally, as we've talked about throughout the presentation, CCAR and DACODS requirements are directly and negatively impacting how people experience behavioral health care in Colorado, especially for intake appointments. For folks who are more visual learners, this user story summarizes much of what we heard from providers about the experience of collecting and submitting CCAR DACODS reports. I'll keep this up on the screen for a few minutes to allow you to read, but I'd say the major takeaway here is that for one client intake appointment, it can take anywhere from 30 minutes to 1 hour to collect and submit SATE reporting. Multiply that by a full caseload and multiply that caseload by a full organization, and you begin to see the magnitude of this administrative burden. These slides are also posted on our project microsite, so you can see these at any time. And I'm going to keep us moving forward. One of the major factors causing an admin burden for this report type today is the data strictness required by BHA tech systems. Said more simply, this means that the BHA requires a customized file format that is not supported by EHRs without customization. That means that it's up to each provider to create unique processes and systems in order to successfully create and submit this file type. Our recommendations highlight and address the need for more data flexibility amongst our technology systems. Finally, we heard CCAR DACODS are inappropriate for many of our priority populations, leading to data inaccuracy. As the BHA has equity as a part of our mission statement, it is incredibly important that we address these different needs across this report type. And I'll talk to you about what we heard about these different groups in the CCAR DACODS reports now. For children, youth, and family, these reports are not tailored to infants and children, so we need to explore other reporting mechanisms and/or ensure that training materials provide specific clinical guidance for this population and how to accurately fill out these reports for these clients that they are not designed for. Undocumented people can be rightfully reluctant to provide information about themselves and their families. We heard several times from providers that they want specific guidance from the state about how to approach reporting requirements with this population. For LGBTQIA+, again, we need to evaluate adding better data element options for gender. We also need to talk with providers about whether it's absolutely necessary to collect sexuality information, or if that information might be better collected elsewhere. For people who speak Spanish, we heard that the race and ethnicity options were particularly confusing and need to be addressed. For unhoused folks, we heard that housing status options are not at all appropriate and need to be updated. And for opioid treatment program participants, the language for drug types and administration methods are outdated. For example, there's no option for fentanyl and vapes, which means that we're collecting inaccurate data today. Changes to the data model and training processes and materials are covered in our recommendations, and we'll seek to address these concerns. I'm hoping that it's starting to become clear how our findings tie one-to-one to our recommendations we reviewed at the beginning of this presentation. And I'll put them back up on the screen in case you want to review one more time, a summarized list of how we plan to address our findings. You can read about these recommendations in depth within our full report listed on our project website. Today, we want to talk briefly about the third recommendation, moving from encounters to episodes of care. Something we've heard from providers across a variety of research efforts at the BHA is that having a more comprehensive understanding of a client's history with state services would help providers to make better care decisions. We believe that we can begin to pilot providing that more longitudinal understanding of a client's care history by linking together different service level reports that we have access to, including CCAR, DACODS, and 837 encounters, for an individual to turn that into a more holistic data story of their past treatments, what has been successful, what has been less successful, so that providers can get that more whole person picture on their first interaction with that individual. This is a visualization of what we mean by moving towards whole person data from encounters to episodes of care. This effort will, of course, require heavy work with people with lived experience in order to understand appropriate levels and methods for gathering consent to make sure that they have agency at every step of their care journey. For the sake of time, like I mentioned, we left the rest of the detail on recommendations for people to dig into their own on the report. Now I want to move into probably what you're very eager to hear. What's the timeline on all of this, and how can folks provide their feedback along the way? This tentative timeline represents what we as the BHA can commit to in terms of moving these recommendations forward. We have data model updates and tech system updates on their own tracks, each with different engagement plans and methods to ensure that we're engaging community and co-designing every step of the way. We'll also anchor this work in pilots and iterative tests to make sure that we're gathering feedback and learnings as opposed to building from a more antiquated civic technology process, which I'll talk about in just a little bit. One of the things to note here, and I can come back to this timeline slide during discussion, but it's important to understand that we will not be requiring any changes for provider data entry for CCAR DACODS for at least a year after our finalized specifications are released. And that's in order to be respectful to the amount of time that we know that it takes to implement these changes into technology systems. Now, going back to the timeline slide, that's not to say that we won't be ready to accept earlier than a 1 year after our final tech specifications, but we're giving providers that full year in order to make that transition. But if they're ready earlier, we might also be ready earlier. So I referenced this before, but I wanted to dig into this point in a little bit more detail. This roadmap is built on the principles of iterative product design and management. That means that we're favoring small bets, iterative pilots, and tests rather than a magic bullet vendor partnership. And that's because, and I'm sure that many of folks on the call have experienced this, traditionally, for the past 30 or 40 years, government technology was built with a build it once for forever mindset. This method means that user feedback is typically not collected until it's too late. And constituents and providers like you all are forced to use bad and antiquated tech until it literally dies years later due to faltering systems and software so old that it cannot legally meet security requirements. This is where we are with the CCAR and TMS system today. The roadmap outlined here instead uses iterative product design and management methodology, ensuring that the tech systems are built for change from the beginning, and feedback it can be provided and acted on throughout its life cycle, ultimately saving the state money and drastically improving user experience. And finally, one of the things that I hope you saw come through in that timeline is that we're building a lot of time for community and provider engagement. So this is the first of a series of share outs that we'll have, but we'll also have time for provider feedback on what that new data model looks like, how we're moving forward with tech system updates. So we plan to gather that feedback at every stage to make sure that we're meeting the needs of all of our providers, from the lowest tech resource providers that don't have Wi-Fi and broadband to our providers with the snazziest EHRs. Ultimately, we know that the success of this project hinges on that accurate, transparent communication. And on the screen are a list of other ways that we've committed to engaging both providers and people seeking care on this project plan. All right. So what's next? What are we asking of you, and what do next steps look like? Well, we would love you to read the full report that goes into more detail than we could pack into a session. And you can also always watch a video of this presentation on the project website. This full slide deck is also there in case you want to read any of the slides in more detail. We have a feedback form, like I mentioned at the beginning of the presentation, that will be open and accepting feedback until October 27th. That's in case you want to provide longer written feedback or anonymous feedback. And again, like I mentioned, the BHA is giving that anonymous feedback option because we're going to be providing a response to each and every piece of feedback that we get and publishing that on the project website that Megan has already shared in the chat. And finally, Megan will also share a sign-up form in case you want to get email updates on this project or other technology projects that the BHA has in progress. So next steps, again, we're going to be collecting that feedback until the 27th. We'll be posting our responses by mid-November. And then we'll be hosting a series of additional share out and discussion sessions on that feedback, very similar to today, right? So we'll have, a certain amount of time for presentation and then a certain amount of time for discussion. And at that time and during those sessions, we'll also be promoting additional ways to engage. For instance, we've been thinking about whether it would be appropriate for a data model working group or a specific, process for gathering provider feedback on the revised data model. And now I'd love to transition us back to open discussion. So as a reminder, this was our key takeaway. We want your feedback on whether the recommendations provided will better balance administrative burden, federal requirements, and measures of quality and access for providers like you. I'm also going to launch a poll. This is a poll that we launched at all the sessions that we're hosting, asking that same question and whether you agree with it or not. I can't see who posts what, so this is also anonymous. And I would love to open it up to questions in the chat and questions live. So I'm going to stop sharing my screen so we can see one another. And it looks like I have a question in the chat already. So maybe I'll begin with that while other people can think of their questions. So the first question I see here is from Elizabeth Martin, who says, curious how any or all of these changes apply if an agency sends all information to the MSO rather than state systems. That's a great question, Elizabeth. And I think that it should still apply. We're one of the things that I think was written in this report, but I didn't mention outward, is that we're also building this plan alongside the plan for the BOSSOs. So there's a lot of unknowns right now around like how that will change, how the BOSSO's responsibility will be similar or different than ASO or MSO responsibilities. So basically my answer to that is we're building this plan in parallel with that plan. So we'll make sure to plug that into one another and provide updates as we can.
So let me just clarify that. What you're saying then is that the MSO's system will also, they're also doing some of this to make it easier on the providers as well. They will be required to make their own changes.
So I think all of the recommendations in this report would equally apply to like MSOs and ASOs as they do to providers. Okay. And I think we have to have each ASO and MSO today has a different way that they ingest data or require data from providers. So actually going into the BOSSO contracts is a good time for this to be happening, because we can write into those contracts, you know, what we think is best practice around this. So it's a little bit of a, I don't know, but we will make sure to share with all of you before we make any decisions on that front.
Perfect.
Is that fair?
Yeah, we have just found that the two systems don't really go together. They don't really mesh well together. So like every time there's an audit, there's like, oh, you missed this 500 people over here. And we're like, no, we absolutely did not. And so it's really hard. I mean, we always figure it out, and so do they, and it's great. But it would just be nice if whatever system that the state uses, it goes well with the whatever the MSO or Diversus or is using up here in Colorado Springs. Then I had another thing. You talked about the people that you talked to about this. You had 60. They had around 60. So we have about 500 a month. Is there going to be any kind of a tier sort of a thing? Are you looking at that, or are you looking at the same for everybody across the board? Let's just figure it out so it can work for everyone. So
that 60 number was the number of folks that we engaged in research from those 16 organizations. Right. So could you restate your question? Because I sort of didn't are you saying like, will there be different data entry options for different types of providers?
Yes, depending on how many people they have in their systems.
Well, I don't know if it's how many people they have in their systems, but rather how they have their technology systems set up. So we understand the importance of, and you know, a lot of times people in these conversations, I think rightfully so, ask about EHR automations and APIs. And our response back to that is that's appropriate for a certain number of providers, but not all providers, right? Some providers will always still need a manual update option. So again, that goes back to building iteratively and also providing customization for providers. One of the things the BHA technology team is doing over, you know, the next however many months is building a comprehensive EHR strategy, which this project will then plug into. But we know that, you know, EHR automations are not the silver bullet. For instance, because of the cost that a provider has to accrue to make those API integrations. So there's a lot of, we're exploring kind of all angles, I think, as you signaled, Elizabeth.
Okay. And then the very last thing, and I'll be quick because I know I'm a little far behind on this whole discussion, but I intend to, now that I know about it, I will be attending all of them. I have one full-time position and one over part. I mean, it's right there, almost full-time position just for DACODS. That's it. That's all they do here. And I have no choice. And so I just wanted to add to the fact that, man, it really would make a difference to what I could pay my people if we could work something out on this piece, because it is such a big deal.
Yeah.
Yeah.
Thank you,
So
Elizabeth. We
thank
heard
you.
that. Yeah. Thank
I
you. No,
bet million times. Is that what you were going to say?
we did. No, I think we heard many times that there are organizations that have many full-time positions just to fulfill the state reporting requirement. And you know, that's not okay. And that's why this is why we started here.
I love it.
Thank you.
Love
it. Thank you, Elizabeth.
Thank you.
Angie has a question that I'll read for the recording. Will there be funding available for providers to update EHR systems to implement the changes? That's a great question, Angie. And so one of the things that we're going to do after we arrive, if I'm going to share up the presentation again, because I want to go back to the timeline. Of course, I exited out of the one screen that I need. All right, so to go back here, so Angie, to answer your question, once we have the tech system selected, and so if you look at this timeline, that's going to be somewhere in the February to April timeframe, we will be better able to do a cost analysis of what the ultimate tech selection will mean for different levels of provider tech resourcing. And at that time, I think would be the appropriate time for us to investigate whether there's funding available and like who would be applicable for that funding. So that's something that I can promise to follow up with you when we know a little bit more about what the changes to the tech ecosystem from the BHA side will look like. I hope that answers your question.
Yep, thank you.
Thank you. What other questions can I answer? These are fabulous questions. Okay, Amy in the chat says, will regular feedback reports of items that may be helpful clinically be built in for providers to receive reports? Honestly, I can't think of any situation in a current system where we have used CCAR or DACODS data to make clinical decisions. So yes and no. I don't think that CCAR DACODS, even with a new data model, will ever be a clinically useful tool. Instead, I think it is a tool for providers, for the state, and for the federal government to understand trends in behavioral health and outcomes and impact on like an aggregate broader scale. So our plan, and also having data analysis available to providers so that they can understand how they are tracking towards contractual requirements and whether they are in compliance. So I think that those are the types of reports that we want to make accessible to providers and to the public, honestly, in aggregate. So I think we're still in like a really early phase about like, what will those reports look like? And we want to be in communication with providers around what type of information would be most useful to you. And so again, it all goes back to community engagement, right? We're going to work with folks like you in situations like this to understand what is the information you want out of this report that we can then share back with you. Justin, go for it.
I just want to reiterate that we are very interested in what would be helpful to return back to providers. So if you do have things on the data reporting side that would be helpful to you as a provider that you would like returned back to you after things have been submitted, please put that into the feedback forms so that we can start moving in those directions, because we do want to make sure that we are returning as much value as we can from the data that we are collecting to providers yourselves, understanding the complexities of consent and privacy and all of those things. So if you do have thoughts on that, please put it into the feedback form so that we can follow up.
Thank you, Justin. Thank you, Amy. Megan and I beat each other to the feedback form promotion, so you double have that link now. Great questions, y'all. What else can we answer for you today?
Hi, this is Dawn Martin again. We're not waiting on anybody, right? I didn't see anybody waiting. Okay,
Nope.
just really quick, I wanted to say, you talked about like the sexual orientation and the stuff like that. I have I believe, and I have heard this from almost anybody who does any sort of screening or in administrative intake type stuff at our facility. Obviously, DACODS is one of the first things that we do. I will tell you that it is an absolute push off to ask almost anything cultural. No matter what, across the board, cultural questioning is a push off for people who are coming to treatment. And the first question that we get is, what does that have to do with my drug use or alcohol use or whatever? So I did just want to add that really quick because I would bet 7 of 10 people will say that. Like, it's a super high number.
Yeah, thanks, Elizabeth. We definitely heard that as well. And I think
Okay.
that I thank you for adding that. I think, you know, what that comment made me think about is how important that stakeholdering around the data model will be, and also, you know, how that changes. I think we're envisioning a system, you know, again, similar to Compass, where we're condensing CCAR DACODS into, you know, one data model, right? And that through some kind of smart logic, Justin, keep me honest here, like we will like indicate what questions are appropriate for different, you know, data needs, whether it's substance use or mental health. And
Very
that,
nice.
yeah, that is like building that front end system so it feels more unified for providers, but that we're still able to, you know, separate that data on the back end, on the state end, to remain in federal compliance. So I say that as a forward to saying that in that data model engagement that we will do, it'll be really interesting to see from a substance use setting, a mental health setting, and a dual diagnosis setting, like which of those information is more comfortable to give. And that might get us to a question to, again, like if we want to go beyond federal data requirements, like what do we feel good about asking? And we'll get into all of this in more detail if anybody wants to kind of participate in that engagement opportunity. But I think it's just a well taken piece of feedback, and we will add that for sure, Elizabeth. Thank you.
I think just an idea, and I'll put this in my form too. If they didn't have to be due so quickly, and we had a clinician who could actually build a little bit of rapport with them prior to asking the cultural questions, I really think that we would have much more honest and definite feedback anyway. So there's just my 2 cents.
Yeah. That's a great point. So Elizabeth, actually, I know that this is true of CCAR, and I'd have to double check for DACODS, but the BHA, or rather the OBH, did put rules in place that you don't actually have to collect that data until later in the care journey. What people found was that, one, then that puts the, you know, onus of responsibility on providers to remember to then fill out that report. And if that person does not come back, then that is like a client that then can't be counted towards contractual requirements.
Oh,
So there's kind
right.
of some pros and cons to talk through around that. But I think it's a really great point, and when we can continue to like talk about with this community.
Awesome. Thank you, Abigail. That's good feedback. I appreciate it.
Yeah, of course. Great question. All right. Well, what we did, we also ended early on Monday. I had expected much more conversation, but you know, it's totally good. I think some people prefer to give their feedback written, and I totally understand that. I'm also that way. So what we will do is the BHA technology team will stay on this call for the whole time in case people want to ask questions. But this is kind of the bulk of our presentation for today. So if you feel like you want to leave, please do. Again, you'll be able to review the recordings in case we answer more questions. But we just thank you for your time and thank you for your really awesome engagement. And you'll be hearing from us shortly. So stay and ask more questions or go, up to you. Just really appreciate all of you.
Thank you so much for taking the time.
Yeah, anytime. Thank you, Elizabeth. Thank you, Melly. Thanks, Amy. Thanks, Katya. Thanks.
May I ask a question? I'm going to be really naive here, but as everyone's jumping off and it seems like we have lots of time.
Yes.
My name's Amanda. I'm a nursing director, but I now have a social work reporting to me and I haven't had time to read the report. Are you able just to summarize the changes that are being made? Just really briefly, just so I have a sense of it and what that reduction of administrative burden looks like.
Oh, that's a great question. So I would say the best summary was on the slide, and I'll share this up again.
Okay, thank you so much.
Yeah, of course. So I would say the best summary is this slide that shows like the 5 key recommendations in addition to the timeline, which I'll share up again in a second if you want to screenshot that. And it's also on the project site as well. But I would say like those 2 artifacts paired together would be a good sort of synopsis of where we're headed.
Okay.
Let me know when you want me to head to the next one.
I'm curious about the communication plan.
Mm-hmm.
Is that to Justin's point, is that communicating out the data or communicating out this project?
Both. So let's go to this slide. So you can like this project will have a couple of different tracks. There's sort of the track of updating the data model, and then there's the track of selecting and procuring the tech system. So those each will have their separate kind of like engagement plan around them. And we will also be doing more comprehensive communication on the entire project throughout like the life cycle of the project. So likely when we present out again the feedback that we've gotten from providers in November, we will provide more detail on what those engagement opportunities for each of the tracks will be.
Okay. So it's a huge project and it intended, right, to gather data for statewide collecting purposes and trends, and then make this easier on the providers who are entering a ton of data. Or yeah,
that's it's
well, appreciate it.
Yeah, improving. I would say not creating a new one, like improving the way that the BHA has to collect data.
I like it.
Kind of the way that we've been talking about it.
That's great.
And if it's okay, Abigail, I'd like to add just a couple of a little bit of nuance there. I think whenever, to your point of this is a big project to do a lot of things, whenever people hear big government projects, they often cringe. You'll notice that this is a multi-prong program that involves several smaller recommendations and initiatives. Each one of those is a relatively targeted and contained goal that addresses a slightly different part of the administrative burden. So updating the data model will probably impact people who ask questions, and then people on the technology side. Updating the technology submission, the technology system for submissions will likely affect the administrative side of the house, but not necessarily the clinical side of the house, unless that's the same group of people. So you won't necessarily see the impacts of every single thing that we do, but in totality, the hope is that A, we reduce the overall burden, and B, that each of these individual projects is not it's not one monolithic whole that will be delivered in 3 years, at which point we look back and say, oh, we got kind of close, but we're doing them as we, small bets, lower risk, higher reward, more iteratively.
Got it. And it did sound like potentially there could be some magical world in which it uploaded this data from an EHR. Is that true?
So yes and no. So there are many applications at the BHA right now, and actually statewide, for EHR like API integration. So what we're going to do as a team is we are going to create a holistic strategy for across all of our products and platforms, and we will stakeholder that and share that out with the team. So that'll likely be more of like a far future effort that happens in parallel with all of this great stakeholdering.
Very cool. You guys have a ton of work. Thank you for doing it. Really appreciate it.
Of course, it is quite literally our job. We are happy to do it. Thank you.
Well, thank you. And thanks for your extra time and taking a little time with me too.
Yeah, literally anytime.
Great. Okay. Have a wonderful afternoon, everybody.
Thank you so
Bye.
much.
Thank you.
All right. Werner, Ryan, or Elizabeth, anything we can do for you? Otherwise, we might shut off a little early.
No, I just kept it running. Again, I was doing some other stuff at the side. One question I had that just come to my mind is: do you envision that initially you'll have an EHR like submission version, or are your initial ideas to go after a web-based solution that everybody has to use, because we are talking about far future for the EHR integration?
I don't know. I think it
Okay.
really depends on like what that, oh, Justin, I'm gonna let Justin go.
It's a great question, and Abigail's 100% correct that it depends on a lot of things. However, on the tech side of the house, you'll notice in that implementation that we are going to be running pilot projects with different groups and different technology stacks over the coming year to understand where our opportunity is for which groups of people, because obviously there's some people who have EHRs. There are a large number of people who don't use EHRs. What is the highest return on investment that doesn't disenfranchise half the industry in Colorado? But to answer your question, we very much want to get to a point where EHRs are doing the heavy lifting.
Yeah, and that's generally been our preference, but we are a fairly large-sized mental health center, and then the main reason is to provide a common interface for clinicians and a common training platform, and to have a fairly good control over what they are doing and what they are providing, and to integrate any kind of reporting into other solutions. Because if you don't do that, then you're ending up having to extract data from the online system, and then you get in the reverse direction, and the effort just goes the other way. And so it's more work up front, but there's generally a benefit of it.
Believe me, I've been on your side of the fence enough times, and I do not love extracting batch upload files. It's not great. But if you are interested in being a guinea pig and helping us to understand the technology, can you please put that in the feedback form and how to get in touch with you or your organization, so that we can get in touch, understand what EHRs you're using, what technology systems you're using, and what your workflow is like, so that we can roll that into our research and understand where the low-hanging fruit is, and where not just the low-hanging fruit, but the most valuable fruit is.
Yeah, we can do that. So, absolutely. Thank you.
Thanks, Werner.
Okay, well, that was a good presentation. I'll let you go. I think we
Alright.
want to go home. Thank you guys. And
Okay.
bye.
No, we're good. We'll just hang out. I have a feeling,
Thank
I
you
think
very much.
Elizabeth and Ryan maybe are not actually present, so I think we'll end the call now.
Elizabeth looks empty. Yes. Yeah.
Or she's a ghost. Halloween.
Who knows? Yes.
And
Well,
and
thank
the
you.
end of the
Yeah.
presentation is now.
Okay, thanks. Bye.
Bye. I'm gonna end.